Alrighty, I think we'll go ahead and get started. So, hi everyone. My name is Hillary Godwin, and I am Dean of the University of Washington School of Public Health. Welcome to our biweekly COVID-19 webinar, where we typically discuss both the university and the school's response to the pandemic. Today we have a special topic, which I'm going to tell you a little bit more about. We're focusing on how COVID-19 has magnified existing health disparities in our surrounding communities, and have a conversation with some of our practice partners from the surrounding community about how we might work better together to mitigate some of these impacts. Before we get started, I'd like to acknowledge that even though we are all Zooming in, that we, from the comfort of our homes and are not on the UW campus, that we are, most of us are, well, all of us, are still doing that from Indigenous lands. So right now I'm calling in from Suquamish territory, but in Seattle, where most of you guys are probably right now, you're calling in from the land of the Coast Salish people, not just Suquamish, but also Tulalip, Duwamish, and Muckleshoot nations. And we honor those people who still live here and on whose land we are guests. As a matter of housekeeping, as you can see from the screen in front of you, we don't use the chat function or the raise hand function on these webinars. Instead, we use the Q&A function. So if you have a question, please enter it into the Q&A. You're welcome to direct that to one of our panelists, or to just leave it open-ended, in which case I'll try and figure out who's the best person to ask to respond. We've hit some really sad markers in terms of the COVID pandemic this week, with more than 850,000 deaths globally and more than 6 million confirmed cases nationally. And as always, our hearts go out to the victims of COVID-19 and their families. And especially this week, I wanted to emphasize that our hearts also go out to the victims of police violence and their survivors. Our plan today is to skip our regular updates so that we can take a few moments to acknowledge the pain and anguish that many of us are feeling in the wake of recent national events. Starting with the police shooting of Jacob Blake, a 29-year-old Black man and father of 6 children in Kenosha, Wisconsin on August 23rd. The protests that followed included boycotts by pro sports teams to show solidarity with Black Lives Matter, and street violence, and resulted in the deaths of 2 protesters in Wisconsin and 1 in Portland. We've also seen deaths of at least 16 people and untold destruction from Hurricane Laura over the last week, the most powerful storm to ever hit Louisiana. And we have another hurricane, Hurricane Nana, that's brewing right now off of the coast of Central America. For those of you like me who have loved ones in California, our eyes are on the wildfires. We have more than 75 large wildfires raging across the United States at the moment. I think we're all feeling pretty blessed right now in the Puget Sound area not to be suffering from poor air quality, but we're sort of the exception as opposed to the rule right now. And on top of all of that, I think we're all torn by the ongoing national political divide, and depressed by the loss of an incredible actor and producer this week, Chadwick Boseman, from colon cancer at the young age of 43. And I just wanted to share with you just a beautiful quote from our former president, Barack Obama, that he tweeted on Saturday. He said, "Chadwick came to the White House to work with kids when he was playing Jackie Robinson. You could tell right away that he was blessed. To be gifted, to be young, gifted, and Black, to use that power to give them heroes to look up to, and to do it all while in pain. What a use of his years." So I'd like for us to take just a moment of silence to honor him and the others that we've lost. in the midst of this pandemic, I also want to take a moment to talk about what we do in public health. We spend a lot of time lately talking about COVID-19, and I want to make sure that we don't lose sight of the larger issues and inequalities that we face as a society and the role that we in public health can and must play in addressing them. In public health, we're dedicated to eliminating health disparities, to fighting for a more just and equitable society. And we can't wait for the pandemic to be over to engage in that work. I want to thank and celebrate each of you who are living your values every day and carrying out your work and research, education, training in areas on this topic. Today, we're really delighted to have with us three outstanding guests who are going to talk about the intersection of COVID-19 and health disparities. They're working in communities that are particularly impacted, and we're looking for insights from them, but also for you guys to engage in some dialogue around how we all might work better together to fight the underpinnings of the inequities that we see, including racism, but other social and environmental injustices as well. So first of all, we have Dr. Benjamin Danielson, who's Senior Medical Director and the Janet and Jim Senegal Endowed Chair of the Seattle Children's Odessa Brown Children's Clinic in Seattle, as well as a clinical professor of pediatrics in the UW School of Medicine, where he received his medical degree. Ben is well known for the upstream approaches he takes to medical care and his work on the underlying social determinants of health disparities. He was both our school's graduation speaker and the University of Washington commencement speaker in 2018, and we're glad to have him back to talk with us today. Our second guest is Adrian Dominguez, who's Director of Informatics and Epidemiology at the Urban Indian Health Institute, Seattle Indian Health Board, where since 2015 he has been responsible for the oversight of surveillance, scientific research, and projects that impact the American Indian Alaska Native population nationally. He has over 28 years of experience as an epidemiologist, is a member of the Board of Directors of the Washington State Public Health Association, and is a member of the Advisory Board for the Network for Public Health Law, and a member of the COVID-19 Network Prevention Latinx Expert Panel, he's going to discuss, review, and provide recommendations for the COVID-19 vaccination clinical trials. Close to my heart, Adrian received his MS in Epidemiology and Statistics from the UCLA Fielding School of Public Health and was a fellow in Neurology and Public Health at Harvard University. And last but not least, we have Dr. Adnan Mustafa, who's an internal medicine and pediatrics physician and medical director at Seymour Community Health Centers in Kent, which he joined in 2014. He grew up as a second-generation Indian Muslim American in Eastern North Carolina, where he came to appreciate the intersection of different cultures. After receiving his MD from the Brody School of Medicine at East Carolina University, he obtained a master's degree in public health at Johns Hopkins University to better serve patients and understand the social complexities of good health. Adnan has worked on community projects in India, Malawi, and the Como Pueblo in New Mexico. We're super, super honored to have all three of you here with us today. I have asked each of you guys just to speak a little bit about sort of what your thoughts are. So we'll go one by one, and then I think we'll just open it up for discussion. I'll warn you, our public health community is not shy, so I see we already have some stuff in the Q&A, but I'll keep an eye on that and direct questions to you guys after we get to hear a little bit from each of you. So I'm happy to call on people, but if anyone wants to offer to start, feel free to jump in. Okay, Ben, you're it.
I was trying to give that don't pick me kind of expression there, but it doesn't work as well on Zoom. But I just wanted to say thank you for this invitation to join this conversation. And I'm just honored to be among all of you, and especially to share this sort of panel opportunity with these two folks that I admire, respect, and learn from so much over time. I am thinking differently a little bit about what I was going to intro, just because the event, the death of Chadwick Boseman has been on my mind in these different ways these days. It's not honoring the moment well enough to talk about art imitating life, but there's something so reverential about the concept of both the noticing and the unfortunate truth of pain being part of the journey of Black and Indigenous and people of color, in particular, trying to do the kind of work that hopefully changes the world a little bit, and how much that that reflection and that impact is just really noticed. And I feel goofy saying that about somebody who's a movie and acting artist, but I also recognize that symbolism is all around us, and it's important to recognize that meaning. So you had me sort of thrown, Hillary, in the early moment there. What I wanted to also share was a little bit about what it's felt like to be working in a primary care clinic that has historically served a Black community and has been continuing to serve a diverse and low-income community through these very strange times. In addition, I've been on some boards and panels that have included sort of governor convened groups talking about issues like the distribution of limited resources, crisis management, planning, and things like that early in the pandemic response, and other resources like remdesivir midway through the pandemic response, midway from where we are now anyway. And more recently, the conversation about the potential of vaccines and what those mean to the communities that we see over and over again in the data, both locally, nationally, and otherwise, that are the most impacted, the most likely to get sick, the most likely to get hospitalized, the most likely to die. The fact that 25% of the deaths nationally are in the Black communities is really telling. And what it is telling to me is just that this pandemic is the great revealer of who we are as a country. It's the great revealer. It's not, it is not actually bringing new information to us. It is revealing information that we have either wanted not to hear sometimes or tried our best to explain in different ways. And it has forced our eyes open, I hope, in ways that are really important. As a great revealer, it also lends itself to, hopefully among this group, talking in perhaps complex ways about how we live into this moment. And that complexity becomes really, really challenging to me. We've talked about in the early conversations with the other state players around crisis management resources and who should get a ventilator and who shouldn't. And in the conversations about remdesivir, I was really struck by how the state conversations wanted to avoid the discussion around racism and disparate impact on communities of color, especially Black, and especially in this state, Marshallese and other Pacific Islander communities. And how that in the moments of crisis and stress, even in the face of strong evidence of the impact of racism, the desire to create solutions without taking into account racism was really striking to me. And it's partly because I know we live in a state where our state public health department, our state governance really wants to be one that is aware of issues of equity and racism. And yet I just find when big decisions in tight moments with big impacts are being contemplated, it is sadly not surprising to me that the consequences of racism are not accounted for in those conversations in the way that they should be. On the good side, it prompted our clinic to talk about creating different ways of making decisions and encouraging others to make decisions differently. And so one quick thing I'll say is that we borrowed sort of from the model of what happens in operating rooms and sort of created this sort of timeout moment. Operating rooms have improved their safety and their outcomes by creating a timeout and a checklist to make sure that a life impacting decision like where you're going to cut and who you're going to open up and what you're going to do has this moment of pause. And I think the checklist is part of that that's really important, but I think the pause, even if brief, is really important in helping us make better decisions. And so we've created sort of an equity pause when we try to make decisions that has us ask a couple of questions. Questions like, are the communities most impacted being part of this conversation? What are the unintended consequences that we might think of in this moment? Are we making assumptions about people's capacities, desires, strengths, or needs as we make this decision? But again, I think it's the pause. I think it's the importance of pausing in this moment and actually taking those 1 or 2 breaths, having that diastole to match our systole in order to make better decisions. And in that pause, intentionally thinking about equity, which is really important. The last set of comments I'll make is around this concept of coming up to a time of vaccination and how, again, I'm in state level conversations and thinking about community level conversations around the prospect of a vaccination. And there's this twinning, this dipole of perspectives that I'm trying to hold around. It is right and appropriate and important that the communities most impacted negatively by this pandemic, which reflects this most impacted negatively by our systems and our society, that for a change, they should be at the very front of the line for the benefits of whatever health interventions might come, including things like vaccinations. And yet, when you have for hundreds of years created systems that have harmed communities, you have to acknowledge that it is not a simple prospect just to say, I am going to offer this, especially this thing called a vaccine, to a community that has very wisely learned not to trust things being offered to it, especially first in line around issues of solutions. So this concept of first brings with it also ideas of Tuskegee and experimentation, and especially as we think about maybe this first round of vaccines are going to be the least effective. Let's just say that's a possibility. What does it mean to then put communities most at risk first and be possibly by design offering them second-rate solutions compared to what might come later? All of these things swim in my head, and I keep coming back to the pain of trying to navigate these spaces as communities that know that they are placed in the worst positions once again for an illness that has such an ability to reveal the worst and maybe possibly the best of us as well. And how does equity hold space in the ways that we make decisions? And I'll pause there.
That was lovely, Nun. Thank you. Adrian, do you wanna go next?
Sure. Ben said everything I was going to say, so I actually, I've been thinking a lot about what Ben was saying as he was talking. And one of the interesting things for me is that as an epidemiologist, I think prior to this epidemic, no one knew what epidemiology was or what an epidemiologist did, right? And so now we're at the forefront and doing all this work. And a lot of the work that we're doing is behind the scenes with the data and trying to make sense of that. And I think the idea, especially lately in the political environment and trying to get a vaccination out, is data-driven decisions are on the attack. And I think we need to really, really be careful about how we pursue things or allow things to be pursued without the correct information, the information that has been adequately assessed to produce the best results. And as a result, I mean, if we do not do that, I find that the populations that are going to be impacted the most are those that are of ethnic minority populations, or those populations that we have ignored. And I think everything that Ben was talking about plays into some of the barriers and some of the necessities as to why we need to really focus our attention on communities of color. I'm doing some work right now on with COVID-19 Prevention Network, where we're assessing and providing recommendations to all the clinical trials and their protocols and informed consent. And it's really interesting to see and to read the information that is being provided by the pharmaceuticals and the stuff that is just not being addressed, or stuff that are not taken into consideration. I mean, in simple things of accessibility to resources, understanding why it's important to really explain these protocols, and to explain what the immunizations, vaccinations can or cannot do, and understand the historical trauma that has created this fear for the work that either science, medicine does because of bad behavior, going back 400 years, and taking advantage of people, communities of color. And so without understanding all of that, I think it's really hard. I mean, being in conversations with like the pharmaceuticals and with colleagues, that just goes over their head. They don't even take into consideration any of the stuff that we're talking about. What they want to do is push things out and get people vaccinated, testing, so that they can have something to say that, okay, here we have a vaccination on COVID-19. But I do think that communities of colors are going to, if we don't do this correctly, are going to be the ones that are going to be most impacted and affected by it. I think what's really interesting, and I go through this a lot because we have access to all CDC's COVID-19 data. And we do reports for each state and several counties where indigenous populations, or a high proportion of indigenous populations. And the interesting thing that I see when we look at the data, when we start analyzing it, is the level of missingness on race and ethnicity in these data sets. And so it's so hard to actually do any type of assessments. I mean, I have some states that all the data that they have provided have no data on race and ethnicity at all. So states like Montana, where there's a high indigenous population, that data does not exist. So I can't really do any of the analyses or assessments regarding COVID-19 and the impact that it has on American Indian, Alaska Native communities in the state of Washington. And I'd like to think that it's because there's a lot going on and people are very busy, but at the same time, when this all started, I think it was intentional, where states were not providing race, ethnicity on the test results and on hospitalizations. And our office was like, why isn't this being provided? I mean, this is so important, because I can tell you right now, based off of what we know, based off of what the individuals that are impacted greatly and outcomes are really poor with certain chronic disease conditions, are those conditions that are impacting communities of color. Those are the conditions that we see high levels in. And all of this again comes back to like what Ben was talking about, and about racism and about institutional racism. And sometimes this, like when we look at this isn't by chance that things are happening like this. There are specific things that are in line to prevent us from doing the work that we need to do so that we can show that these are the communities that are truly at risk and need our help to get through and manage through COVID-19. And you can look at all the different risk factors and behaviors and what have you, and all of that information is literally missing. Now, if I go and I look at data from these various states and I look at white non-Hispanic data, that data is present. And so it's really discouraging that I can do analysis and any type of research on white non-Hispanics, yet communities of colors, it's very, very difficult to do that. So I think that for me, that's one of the things that I think we need to keep on pushing as universities, our organizations, community partners, hospitals, state health department, local health jurisdictions, that it is so important that we provide racial and ethnic data on the information that is being collected. Because without that, we will not understand the true implications that this disease has on communities of color. I'm going to stop there.
Thanks, Adrian. Adnan, you want to say a few words?
Sure. I don't have any financial disclosures, but I do have a personal disclosure that I have a public health crush on Dr. Ben Danielson, and to be on a panel with him is my first, and this will be, I might take a picture by the end of this, so if you see a camera up here, it's to show my parents where I've come and where I hope to go. And if at the end of my career I get even close to that, I'll be a success. And so where to start? I mean, just so people know where I am, I'm in Kent, which is like the 10th diverse city, even including like New York City and all that. Work in a community health center, uninsured, mainly Latinx community, but a mixture of refugee populations. And I mean, the moment COVID started, I had a feeling and knew that this is just going to be a repeat of any other chronic disease and any other health indicator we know. You look at the King County maps for disease, and you look at the COVID map now, it fits exactly. You take any healthcare risk factor, and anybody in public health probably saw that coming. And so like a couple of weeks in, I just knew that was going to happen and worried. And then the data started coming out. I mean, for those that don't know, I don't know if you guys have discussed it or not, but it's like, I think in Washington State currently, Latinx population makes up 13%, but they're 42% of the cases. And so obviously it's impacting CMAR community health centers a lot. We're trying to do our part as far as testing and whatnot, and radio ads, and trying to build that trust and trying to get word out into the community, but it's limited, as the two panelists before us discussed, like when the structure of the society is baked into the bread. And so to build something on top of that bread and to act like it will, whether it's testing or a vaccine, whatever it may be, you're going to come back to the status quo eventually of inequities. And so personally, I think the George Floyd rebellion during this time might be the biggest blessing that might come out of all this in a sense. In my lifetime, I've never seen any movement towards something that might be a solution. And I don't think there's any like XYZ answer, but the movement itself is the biggest solution I've seen towards these things that we'll just see over and over again. This year is COVID. Let's say next year is going to be some other disease. These diseases are supposed to increase year after year. So I'm interested in discussing COVID, and I realize the urgency of it now, but it's going to be something else in a year. It's going to be something else in 2 years. It's going to be something else in 5 years. And unless we dismantle the home, not using the master's tools, we're going to be back at the same spot. Yeah, we see it day in, day out. Some personal, like some stories on the ground. I mean, as a physician, I'm trying to think of some stories I wrote down, like 70-year-old patients that want to be cleared for work so they can make a living after having to take a break to avoid getting sick with chronic diseases. Multi-generational households with 10 people in the house all infected with COVID. another multi-generational house that I take care of the whole family, and the grandfather or the oldest person in the home had multiple comorbidities. He died from COVID in the hospital. His son got clots and was admitted for weeks. And he has like PTSD from that and grief and all that. And when I'm seeing him for follow-up, his first question is, when can I return back to work? We know the solution, like, and it's gonna have to come from something beyond what we're, I would say, politically feasible of doing. And I'm hopeful, I like talking to students because it's not gonna be, it's gonna be you guys hopefully dismantling it and just starting all over. Because if you guys are a public health crowd and you know what it takes housing, it takes wealth, it takes justice, and no amount of legislation is going to create that, in my opinion. It can be part of the solution, but it's going to be much deeper than that. And unless this country is willing to kind of grapple with property, purse, and like really changing that narrative and changing what that equals, you're going to have the same issues. I mean, Latinx people, are they getting it? Crowded homes, working in meat plants, working in agriculture. Even in California, I saw a video of people picking fruit with the wildfire behind them. Our sense of humanity, and I'm part of this problem too. I mean, I'm getting that fruit. What if the fruit I ate this week comes from someone that picked that fruit? And so it's not to say that I'm jaded. I'm actually, this is the most inspired I think I've been, and during my career, as far as because of the George Floyd rebellion in the midst of COVID. And I don't think it would have happened without COVID too. So maybe there's some divine intervention in all this and something good will come out of it. But 100% support the epidemiologic studies and all that. But like studying what people need, that's pretty obvious. It's just a matter of making it happen. So listening to activists in your community, locally, we have plenty to follow. And for us to kind of remain in diastole maybe will be a good thing, as Dr. Danielson said, and let the other people do the systole that have been doing it for years and have had the answers for years. And now they're getting somewhat of a platform, which I'm excited about. I'll stop there for now.
Thanks. So before we get to the questions, I noticed something in the background behind you, which I think I recognize what it is. And I just want to call it out because for me, this is like one of the greatest joys of COVID and being on Zoom. I really miss being with people in person. I'm a people person, but I love it when I see little people and like, it's like this like, hooray, like we can finally all acknowledge that we're human beings and that we have families and lives. So I thought I saw a little person behind you. Do you want to introduce them?
It's someone sitting.
Oh, darn it. I thought it was a kid.
It's a budding med student that works as a care coordinator here that I invited to just join in. But he's sitting. I told him to just stay out of the picture, but he's nice guy.
You can tell him that he faked me out, that I thought he was a child. That was like, darn.
He does, yeah. He is young.
Okay. With that disappointment, we turn back to the questions from folks. So one of the first questions that we got, and it sounds like this might be one for you, Adrian, is how do we prevent bias in health trend algorithms, especially those publicly reported, and how do we prevent bias in their use?
You know, I think that what's important, if we're talking about bias in the sense of that this is the understanding, or this is what we think certain populations, certain communities of colors, well, that's what they do. That's why they get the disease. These risk factors and these behaviors are expected of them. I think what's important is to understand, and this is where it's going back to, it's not just about the present of what has been happening as a person gets the disease, or, you know, we have to look at historical components to have an understanding of populations. And I think by understanding why things are the way they are, gives us a better ability to do research in a culturally attuned way. I think it's important to not just to do research or any type of surveillance that is Western specific, but also to incorporate cultural activities or things that are specific to cultures, the communities of colors that, in a sense, are strength-based, and so to measure how that can potentially be an intervention in communities, rather than just to focus in on the negative. I think the other thing that, when we're talking about the biases, in some instances, when we just focus on the negative and don't just stop there, and we stop there, we tend to then add to that bias on these outcomes. And I think it's important. I tell my staff, I know a lot of the stuff that we talk about or that we see, I know all that information. What I want to know is something that, what are the strengths in a community that will help that community address, prevent what's happening with COVID or what's happening with chronic disease. I think that's the thing that's important to understand. And I can't stress enough as well is that it's really, really important that we have clean data, we have data that is accurate, that data that represents the community. There's a lot of data misclassified, particularly with like American Indian and Alaskan Native. And so if it's misclassified, we don't see, and they put it into a strata that is, for instance, white. We don't see the positive outcomes that's affecting that category or that group of people. So, so that's what I can say about that. That's my thoughts on that.
So, Adrian and Ben, you both brought up about sort of that we're going to face some challenges in terms of distribution of vaccines, and that those invariably will be influenced by and influence social disparities. What are your thoughts in terms of how we might go about this in a better way? Do you have sort of some proposed plan of action for decision-making by medical, government, pharmaceutical companies? That's social, that I love this quote from the person who posted that is socially discerning in a compassionate and balanced way.
I'll start off, but I actually want to also just reference what I felt I heard Adrian and Adnan say about, I'm just thinking about data for another second, and just maybe this is a moment for us to call for enormous change instead of incremental change. And a lot of us have spent our time like really working the margins on incremental change. And I would include our attitude towards data around that. And just hearing Adrian and really reaching into this, what if we embarked on a mission of data liberation? And what that could mean is that we are not the arbiters, the namers, or the describers of data at all anymore. And that the data, that four-letter word is no longer a four-letter word because it talks about stories and lived experiences and the perspectives that reach generations, as was mentioned. What if for every answer that we're talking about today, we talk about it in the context that Adnan was mentioning about, this is our one chance in maybe 50 or 100 or some years to really say everything we talk about has to be huge. We have to, as huge as my hands look on this screen right now, like we have to be thinking about transformational rethinking, so that even when you asked that question, Hillary, like it felt like you were centering traditional places that consider themselves the knowledge centers naming a process. And like, what if we blew every idea up and reframed and even asked the questions differently? I wonder what that would look like. I know that if you want me to get to the vaccine piece, it is so common for us to make this mistake in the systems that I am guilty of being a part of, where we get to the last moment and then suddenly we want to have a meaningful conversation with a community about something when we should have had those conversations for generations now. We should have been having these talks, these conversations in ways that would not make us have to ask this question: how do we do this right now in this moment, in the next 5 minutes, to make sure we make the best decision that in a system that is already so, man, I'm really trying not to swear, but it's like so built to be dysfunctional and harmful, like killing people, harmful. I want to rethink these questions a little bit and think about what is the situation where this is done in a much more honest, respectful and dignifying manner. So what is a dignifying way to think about getting vaccines to people? I'm actually interested in Adnan's and Adrian's perspective on that. Sorry for that weird response.
Yeah, I think that's a great way to think about it, Ben, and I think that's the challenge, right? I will say this, in the assessing so far the 2 first clinical trials that are out right now, one of the things that is so frustrating for me is that of all the people that have signed up to participate in these clinical trials, people of color make up only about 20% of those that have signed up so far. And the pharmaceuticals who are doing the clinical trials don't seem to understand that that's not happening by chance. There are people out there who have this total distrust, and yet the pharmaceuticals, and you're trying to push something out so quickly, so that someone's going to be the first to do this and make all this money, or you have a president he's going to be reelected on this, without truly understanding these communities. We're going to fall short again. And then we're going to try, we'll blame the communities. Well, they didn't want to participate. We made it available, but they didn't, sign up for this. I think we have to be intentional about going out into the communities and talking to them and having them really put together, the process on how to do this, right? The pharmaceuticals still, the 2 that we have reviewed so far, are collecting specimens and are not telling, based off of the informed consent, are not telling the individuals that those specimens can potentially be used for other research projects. We haven't learned our lesson, and we continue to do that. And so I think, Ben, it's about people in our, positions, our ability to talk on that behalf, and put our feet down and say, no, you're not going to do this. You can't do this, and this is why it's important to understand that this has to be done in a certain way that honors these populations, their culture, them as individuals, and not treat them as a number, for scientific research.
I'll just piggyback really quick after Dr. Danielson, what he has to say, like how to have a dignified approach. I mean, when a pharmaceutical company is one of the leading industries and the leading lobbyists in a political year, how are you going to build that trust? I just don't think it's possible. I don't think it's possible. And of course, CMAR is going to try, and we're going to be like try to be the link between the community, but people aren't naive. These aren't sheep. And so, and who's going to sign up? I wouldn't sign up for a new vaccine and the history of what that entails. And so like, unless there's money, unless there's something like meat involved, I agree with Dr. Danielson. It's like I think it was Carl Taylor, who's a public health giant, that said like, if you want to do anything meaningful, play with the kids for 6 months, then go to your next step. We won't have time, but if you haven't done that step, then it's going to be really hard to go forward.
I'm scrolling down. There's more about data. So, you know, I just want to pick up on, you know, Adrian, something that you were saying that was so awesome was the sort of reframing of I hear a lot of like, how can we get these communities to trust us and to sign up? And you were flipping it much more on the like, how can we use our positions that we're in to put pressure on the pharmaceutical companies and the people running the vaccine trials to do a better job and to be more trustworthy. And that to me, like, that's a lovely, like, really important reframing of the issue. So I just wanted to thank you for that. That was sort of one of those moments for me. I'll let you guys take a look at the Q&A. There's I don't even know where to start. It's just, there's a long series of questions here.
There's something about on the ground, like certain groups having higher rates. I see one about Pacific Islanders. It's just like any other disease, to be honest. I mean, I have a good amount of Pacific Islander patients and Latinx patients. I mean, they're the ones working in factories, working in slaughterhouses, working in fields, not getting a day off, having to work in close proximity, living in close homes, and not having health literacy, not having literacy, not having resources. So what does that equal? And so, I mean, the on the ground is that it's rough. People aren't able to put food on the table. People are struggling to pay bills. Collective anxiety and depression is probably the highest I've seen in my short time practicing. The amount of antidepressants and therapy and suicidal patients. And I think it's probably globally having that impact. And so this other, like, I did the public health dance and I did biostats and epi, but I'm all about data and studies, but I really, if I just convince the students, there's lots of studies that we've done, and just if you just stick with the basics first, and like I feel like Dr. Danielson was saying, we're studying a lot of nuances at this point, and to get back to the basics and how to do that. If you can't do the basics, to add nuance onto that is really tough. And Adrian talked about like it's just like a community asset mapping approach, or like amplification, of course. And that's why like the Latin paradox they talk about is for Latino paradox, with them being healthier and what a collective family can do. Those are of course assets that affected communities could use. But I just worry about a narrative more and more putting like the personal responsibility and putting it on communities and putting it on innate characteristics versus just like, we're the richest country of all time, and probably one of the richest counties of all time in this current one. And so like, what do we collectively think we can do and implement now and go from there?
I'd love to sort of bring us back out again to, and you're sort of, and I'm sort of pointing us in that direction of the question of, as public health professionals and the public health community, how can we lift our gaze up from this sort of the chaos of the moment and make sure that we're using that positionality to the best effect to make sure that we're both helping and also that we are looking at the long-term big picture issues.
I'll just start with saying, I think that the biggest, most challenging times are so often the most revealing about opportunities. And I also feel like this time, from a health perspective, has, as Adrian talked about, has made the role of public health at least more discernible, more apparent. And again, I want to think big, and I want to think about how our country disproportionately invests in healthcare instead of public health. And we know what we get from that. We get worse health. I wonder if this is the stage where a public health oriented group of people can really make an organized, I mean, there can be all kinds of protests, right? This is maybe the moment of protest, and organize around the idea that this country actually needs to invest rather than what it's been doing, which has been divesting in public health, and understanding how public health is the bridge in so many ways, potentially, from communities to areas of science, from communities to areas of healthcare, from communities to systems, in ways that could actually make a two-way bridge much more apparent and be a major change. A way, I think, public health could be the bridge, the door that opened up the voice of communities to the spaces that still hold very strongly onto their power, and at least make it very clear what communities are needing, are saying, where their strengths are, what they're calling for, and create a bit of accountability. I really wondered when we were talking about these drug company things, what if you held anti-racism accountability to the results, the outcomes, the salaries, the whatever a drug company really valued greatly. Be interesting to construct a system that really created that kind of a feedback mechanism. What if public health were the voice, the process that was transforming systems on the inside by opening up those doors for communities to be more part of it? Again, I'm sorry I'm talking at such a high level, but I really do think, I know that in our clinic, I'll bet, and Adnan's as well, we did a lot of redesigning of care just in the moment. Between March and April and May, we were just reimagining and then redesigning our healthcare model. And a lot of those things were probably ideas that we just have to really keep exploring and seeing whether we can take them further. What does it make sense to have a healthcare system that makes it so hard for an essential worker to actually come and see us during regular hours because most of our resources are so focused on the times when somebody only with great privilege can come in and access this? How do we create sort of what is that in a board meeting or something where you just call the question? We have to call the question on having everyone have free and fair quality access to healthcare in our systems, and what can we do together as allies and colleagues and future colleagues to say enough is enough? It's so obvious. How could we make any other conclusion than healthcare needs to be driven by the communities for which it is most impacting, and it has to be one that everyone has access to and everyone can avail themselves of and everyone has a prospect of benefiting from? How can we not be asking these questions right now? And I do worry that the specific questions about that we're stuck in right now around vaccines and things like that are, I don't know, my mom would have said, this is the way the man keeps you from doing things, by keeping you distracted in the moment of quick and temporary decision making. So I want to call us all to what's the higher level here? What's the bigger conversation we should have? I'm going to stop on all that stuff now, but I just wanted to share.
Use the values to inform the science or inform the work versus just looking at it solely as science that's numbers, put put value on it, put judgment on it, I mean, I have to see a patient soon, but I mean, like, as far as like value, like, how could the abolition movement inform vaccine practices and like public health, like something along those lines? Like, the abolition movement is based on putting more money in public health and resources in the hands of the people. So like, maybe that should be an approach to be studied. That I would love that study. I would look at that study. And so like, there's many ways to look at it versus just the traditional models.
So can I just add to that? I think, you know, it would be, I think it would be really great. This would be just a wonderful way to attack problems. And that is to go to communities of colors, literally go into those communities and have them actually tell us what is needed, what is, you know, in hard times, and if you really think about it, you know, communities of color, they're innovative because they have to be. They survive things. They're resilient, and those stories never get told. And I think that's the important thing, is that if we could just turn this around and talk to like pharmaceuticals, like, you know what, you don't have the answers. The answers actually lie in the communities, and I think if we took that approach, understanding how, why are these, populations still able to function even after all of this that is happening? It is, if we took that approach and understand what it is that they're doing to be resilient, I think we would have some better answers than continuing to do the same thing over and over again.
Any final last words? I almost feel like we should, that was so perfect, we should just end right there. But I'll give you guys an opportunity if you have any final last words that you want to say.
I hope all of us, every one of us is asking ourselves the question, what is our movement? What is the movement that we want to be part of right now? What is the revolution, not the evolution, that we want to see happen? And how do we pull every bit of ourselves, like you said, Hillary, our positionality, our voices, our opportunities that others might not have, our privilege, and our just persnickety, obstinate pushiness. How do we make sure, because the moment that we're in right now, that is responding to so many deaths, so much harm, so much historic harm, and so much present awareness of harm, it is this one chance that we will have, in my view, to make big changes. What is your revolution? What is your movement? And how will you step into that and be who we are supposed to be right now?
Well, that's going to be where we're going to end then, because that was an amazing statement. And I just wanted to thank all three of you and all the folks who joined today. But thank you so much for the work that you do every day, but also for taking time out of the chaos of the everyday to spend this hour with us. And I feel like, we've talked about some really important and challenging things, but I feel hope from the conversation that we've had, and these sort of opportunities to like take a moment and, as you said, pause and reflect are the things that sort of keep us going, that feed our souls during this time. So thank you all for that gift, and I wish you all well. And thanks to everybody who joined today, and stay healthy and stay strong.
Thank you.
Thanks.
Thank you, everybody.